interventional procedures, and surgery. The interventional procedures are what we're interested in, and these refer to nerve blocks and caudal epidural injections done under image guidance using steroids and local anesthetics, and percutaneous disc decompression. Percutaneous disc decompression usually refers to the insertion of some form of energy device under image guidance into the disc to cause the disc to shrink. This includes IDAT, Nucleoplasty or RF coblation of the disc nucleus, or some companies which offer a combination of nucleoplasty, annuloplasty, and discectomy. Today's lecture is focused on percutaneous disc nucleoplasty, as this is the treatment of choice across the Parkway hospitals for disc protrusions. What is nucleoplasty? Essentially, it's the percutaneous, minimally invasive method of disc decompression, which involves the insertion of a small, thin electrode to vaporize tracts within the nucleus pulposus. Essentially, an electric current at the frequency of radio waves or an RF current passes through the spine 1 electrode, and this excites the electrolytes in a conductive medium to form a precise focused plasma beam approximately 1 nanometer thick at the tip of the wand. The plasma's energized particles disrupt the molecular bonds within the nucleus pulposus, dissolving the nuclear material through molecular dissociation and creating short gas tracts or channels. Temperatures generated during nucleoplasty are between 40 to 70 degrees Celsius. Most of the heat is concentrated in the plasma beam by the ionization process and is focused therefore at the tip of the wand, so heating of the adjacent tissue is minimal. This allows treatment of smaller discs, such as those at the cervical level, with minimal risk of thermal injury to adjacent vital structures compared to other modalities. It also preserves the integrity of the neighboring nuclear tissue, maintaining the flow of nutrients to the cells of the nucleus pulposus, resulting in increased cellular rejuvenation after the procedure. So the overall effect of nucleoplasty is the loss of nuclear volume along the channels created. This reduces intradisc pressure and causes shrinkage of the disc with resultant relief of pressure on the nerves, which in turn reduces the chemical and mechanical forces causing pain. The procedure time for nucleoplasty is short. For lumbar nucleoplasties, 6 channels are created. Each channel is created over a period of 8 to 10 seconds. The overall fluoroscopy time required for a nucleoplasty per disc is probably less than a minute for straightforward lumbar discs. The cervical disc nucleoplasties are even shorter because only 3 channels are required. So in summary, we like nucleoplasty because the tissue destruction is controlled and sufficient. The small size of the introducer needle and the focused plasma beam at the tip of the electrode reduces the chances of epidural fibrosis and discitis. The lower temperature limits damage to the adjacent healthy nuclear tissue as well as the end plate cartilage. Neovascularization following the procedure induces healing and regeneration of the disc. This is a diagrammatic representation of what happens during nucleoplasty. You have here a disc bulge causing impingement on the adjacent nerve root as it exits the foramen. Nucleoplasty needle is inserted. Short channels are created in the nucleus pulposus, causing shrinkage of the disc and retraction away from the impingement on the nerve root. This is a picture of the spine 1 electrode. Notice that the distal end is angulated, and this allows the direction of the tract to be changed upon rotation of the wand and extension of the tip of the electrode through the nucleus pulposus. The indications for nucleoplasty are primarily for disc bulges. That means less than 30% protrusion and non-desiccated discs. It's less useful for disc herniations and is not indicated for sequestrated discs or desiccated discs. There should be MR evidence of a contained disc bulge, and the patient's symptoms should correlate with MR findings. The first step will usually be conservative therapy, followed by a nerve block. If this fails, then this is an indication for nucleoplasty. In Parkway Radiology, we have been performing nucleoplasties for the last 12 years. On average, 100 to 150 cervical nucleoplasties and a similar number of lumbar nucleoplasties are done annually. All cervical nucleoplasties are performed under CT fluoroscopy, and all lumbar nucleoplasties under fluoroscopy in the angio unit. Most cases are day surgery cases, and they are performed under conscious sedation with the help of an anesthetist. Our success rates are pretty good, 75 to 80% success rate, with symptomatic improvement within the first 2 weeks and progressive improvement over the next 4 to 6 weeks. In general, we find that cervical nucleoplasties respond faster and do better than the lumbars. So far, we have no major complications with these procedures. This slide illustrates the efficacy of nucleoplasty in miscellaneous publications. I draw your attention to Professor Ganji's textbook on imaging in percutaneous musculoskeletal interventions and the results that he describes with his nucleoplasties. I'm sure you're all aware that Professor Ganji is one of the pioneers of nucleoplasty. We come now to the technique for lumbar nucleoplasty. This is usually done under fluoroscopic guidance in the angiography suite with the patient in a prone position. Conscious sedation with the help of an anesthetist is provided, and a 17-gauge Crawford needle is inserted into the disc. A spine 1 electrode is then inserted coaxially to perform the nucleoplasty. Test coagulation is performed by sending a low-dose electric current through the electrode into the disc to ensure that there is no neural stimulation. Once this is ascertained, coblation commences. 6 0.5 to 1 centimeter long channels are created by extending the electrode into the disc over an 8 to 10 second period with the machine set at the coblation mode. Rotation of the spine 1 is then performed in between each coblation track at 2-hour intervals around the clock face to extend 6 tracks in different directions. This is a good case to demonstrate a typical lumbar nucleoplasty. The MR shows a mild disc bulge at L3, L4 and a slightly more prominent one at L4, L5. The level is first localized on AP screening. The tube is then rotated obliquely to about 45 degrees so that the Scotty dog is nicely formed. You can see this is my daughter's pet Scotty dog with the head and the ear located between the posterior and the anterior end plates of L5. This is the head of the Scotty formed by the transverse process. The tilt of the tube cranially is then performed to ensure that the inferior end plate is flat and the target is just in front of the ear of the Scotty dog. The reason why this is chosen is because in this position, the nerve root runs posterior to the Scotty dog's ear. So by doing this, we avoid hitting the nerve root as the needle enters the disc. The final position of the Crawford needle is then checked on AP screening to ensure that the tip is beyond the medial margin of the pedicle, and anteriorly it is nicely sited within the nucleus. The electrode is then extended into the disc, and we make sure that the tip does not extend anterior to the anterior margin of the vertebral body, because just anterior to this is the aorta. The L5-S1 disc is generally regarded as the most difficult disc to enter because of the marked lordosis at the lumbosacral junction. However, with a steep oblique and a cranial-caudal tilt, the golden triangle, which is the target point of entry for the needle at L5-S1, is easily visualized, and this triangle is formed by the inferior end plate of L5, the iliac crest, and the anterior margin of the Scotty dog ear. Note the RAO 51 degrees and cranial 16 degrees tilt. A caudal epidural injection is often given to bridge the lag between the end of the procedure and the onset of symptomatic relief, which can sometimes take up to about 2 weeks. A 22-gauge spinal needle is inserted into the epidural space under fluoroscopic guidance through the sacral hiatus. A small amount of contrast is injected to confirm satisfactory positioning of the needle tip before a mixture of dexamethasone and marcaine is injected. Usually approximately 20 to 24 milligrams of dexamethasone is given. An ipsilateral exit foramen nerve block may be performed during withdrawal of the Crawford needle after the nucleoplasty. Under fluoroscopy, the tip of the Crawford needle is placed at the level of the exit foramen of the nerve root, and a mixture of dexamethasone and marcaine is injected. A facet joint injection and a contralateral exit foramen nerve block may also be performed at the same sitting if the patient's symptoms are clinically appropriate. What's the role of the discogram? Some centers advocate a discogram prior to a nucleoplasty, but we don't do that in our centers. We feel that we can actually feel the change in consistency as the needle passes through the annulus and enters the nucleus, so that we know for sure that the needle tip is within the nucleus. Injection of contrast during a discogram sometimes obscures optimal visualization of the electrode tip during nucleoplasty. Excitation discograms are sometimes painful, and it may or may not be diagnostic. And we generally try not to give a trial of steroid injection into the disc, because this is an additional procedure, and each additional procedure carries its own inherent risks of infection and discitis. We move on now to cervical nucleoplasties. These are performed under CT fluoroscopy with the patient in a supine position and with the neck hyperextended and held in place with the help of a chin strap. A planning CT with intravenous contrast is given in order to opacify the nearby blood vessels, which we need to avoid during insertion of the needle. The disc is identified upon perusal of the images and counterchecked against the sculpt film to ensure that the correct disc level is accessed. A 19-gauge Crawford needle is then inserted into the disc, and through this, the spine 1 electrode is inserted coaxially. Coblation is performed during a 180-degree rotation over 6 to 8 seconds. The needle is then pulled back by 1 to 2 millimeters, and the procedure is repeated another 1 to 2 times to create a total of 2 to 3 ablation tracks. The end of the procedure may be followed with an exit foramen nerve block, plus minus a facet joint injection, depending on the symptoms that the patient has. This is an illustration of how the needle is held in place and advanced under CT fluoroscopic guidance. This white stick is our secret weapon for the success of our cervical nucleoplasties, as the open C ring allows us to hold the needle in position and to change the angle of entry into the disc to avoid the adjacent vessels. Pressure with the stick also helps to push the oropharynx and trachea medially to create a space so that the needle can enter the disc safely. Structures to look out for and avoid during a cervical nucleoplasty. Well, obviously the large vessels, which would be the carotid artery and the internal jugular vein, the vertebral artery before it enters the foramen transversarium, especially for the C6, C7 disc, the thyroid for the lower disc, the submandibular gland for the upper disc, and of course the oropharynx and esophagus. This is a good illustration of how a standard C5, C6 cervical disc nucleoplasty is performed. C5, C6 is generally regarded as one of the easier discs to ablate. You have here the carotid artery and the vertebral artery, as well as the thyroid cartilage. The needle is advanced under CT fluoroscopic guidance towards the space between the carotid artery and the cartilage. The radiolucent stick is then used to push the cartilage medially so that there is a larger space between the carotid artery and the cartilage for the needle to enter the disc in an oblique direction. Once the needle tip is satisfactorily sited within the disc, the electrode is inserted coaxially. Check that the tip of the electrode does not project into the spinal canal, and disc ablation can safely be performed. The procedure is rounded off with an exit foramen nerve block, and the spinal needle is advanced so that the tip of the needle is placed right at the entrance of the exit foramen for a mixture of dexamethasone and marcaine to be injected. Nucleoplasty at C3, C4 proves challenging because of the submandibular glands. In general, we start from below and the needle enters the skin at about the level of C4, and the needle tip is then walked upwards under CT fluoroscopic guidance as such. This is a good illustration with the submandibular glands here. The needle tip enters a little bit lower, below the level of the submandibular gland, and is extended superiorly behind the submandibular gland up to the level of the C3, C4 disc, while moving the CT table progressively outwards until the tip of the needle is well within the disc, and nucleoplasty can be performed. Cervical nucleoplasty at C4, C5 is generally regarded as straightforward, but do be aware of potentially large piriform sinuses so that you don't end up placing the needle through the piriform sinus. These are often seen in patients with obstructive sleep apnea or when nucleoplasties are done with the patient under general anesthesia. At C6, C7, we want to avoid puncturing through the thyroid gland or hitting the vertebral artery. This is usually the preferred trajectory of the needle, posterior to the internal jugular vein, anterior to the vertebral artery, and posterior to the carotid artery. As such, post-procedure care involves lying flat in bed for 1 to 2 hours, plus minus prescribing a cervical collar for patients with cervical discs. The patient may be referred for physiotherapy. Remember to remind them no excess bending and lifting for the next 10 days or so. The procedure is usually done as a day surgery case, and the patients may be discharged 2 to 3 hours after the procedure. Complication rates are regarded as low, and they generally depend on the operator experience. The complications include discitis, paravertebral hematoma, neural and vascular injuries, pneumothorax or low cervical lesions, and injury to the vertebral end plates. But these are usually seen in higher energy disc decompression devices rather than nucleoplasty. In conclusion, ladies and gentlemen, nucleoplasty is considered to be relatively safe as there are fewer complications compared to other treatment modalities, and it is easy to perform, especially with good imaging techniques and for the trained interventional radiologists. The results are excellent, with good pain relief without having to subject the patient to a surgical procedure, as it is minimally invasive. And on that note, ladies and gentlemen, thank you for your kind attention.